Good afternoon and thank you for joining us today. Our health and our access to health professionals is vital to us all. I'd just like to take a moment now to acknowledge the dedication and hard work of our health professionals in the province. Doctors, nurses, paramedics, pharmacists, personal care attendants, social workers, psychologists, and all of our health professionals have risen to the occasion through COVID, and they rise to the occasion each and every day. Their care and compassion throughout the pandemic has been exceptional, and it's made things far more smooth and successful. People in Newfoundland and Labrador, like people everywhere, want to lead healthy, productive lives, knowing that access to appropriate, quality health care is available to them when they need it. We know we have challenges in our healthcare system. Some have been around for some time and require significant change. Some come from our aging population and how we live, and still others come from the pandemic. None of us, however, can tackle these challenges on our own. We need a collaborative approach to finding solutions that benefit us all. Recruitment and retention of physicians and other healthcare professionals are ongoing issues for many jurisdictions, not only in Canada, but around the world. The situation here in Newfoundland and Labrador is no different. Over the years, we've made significant investments in programs and services aimed at attracting and retaining physicians in our province. We have a medical student bursary program, which includes a $7,500 bursary for a fourth-year MON student in exchange for 1-year return of service. We currently provide $935,000 each year for a medical resident bursary program, with amounts ranging from $25,000 to $90,000 for residents in exchange for 3 years return of service. We have a travelling fellowship program, which provides funding for salaries, benefits, and administrative costs for training that's not available at Memorial, but is available at other Canadian universities. This is in exchange for 1-year return of service for every year we fund. These initiatives alone represent an investment in our future physician workforce of approximately $1.42 million every year. In addition, each year we invest in a family practice renewal program. This is a joint initiative between the Department of Health and Community Services and the NLMA to support primary care physicians. There are 3 core components to this program. Firstly, family practice networks. These provide a structure through which physicians have the opportunity to address practice needs and local population health needs in a collaboration with their regional health authorities. Among the goals of the networks are improved recruitment and retention of family physicians, particularly in rural and underserviced communities. They also serve the establishment of collaborative, community-based, multidisciplinary teams. Approximately 430 physicians are members of one of the 4 family practice networks that this program has set up. Secondly, the Family Practice Renewal Program has a fee code program. This provides specific additions to the MCP payment schedule to recognize complex patients. Currently, it pays physicians an extra for collaborative team-based care and for activities such as conferencing with other professionals regarding a patient's care. Finally, there is a practice improvement program. This provides education and support to physicians to help them with clinical and operational issues. This program is working with MUN's Office of Educational and Professional Development to develop and implement a robust program for family physicians who are starting a new practice in the province, moving from one practice to another in the province, or transitioning from active practice into retirement. The Family Practice Renewal Program receives $4.5 million annually from government under the Memorandum of Agreement between government and the NLMA. Yet despite these investments, we recognise that we must do more. Health Accord NL was created by our government to look at our current healthcare models, to reimagine our healthcare system to best deliver services that can meet your needs in your communities. It's comprised of 6 committees, one on ageing population, digital technology, hospital services, community care, quality healthcare, and last but by no means least, the social determinants of health. The work of Health Accord NL includes consideration of how physicians and other healthcare professionals work together to meet the province's healthcare needs, both in hospital and in community settings. Health Accord NL has already undertaken extensive consultations. Public engagements will continue into October and November, and I encourage you to voice your opinion if you've not already done so, and maybe again if you have. The Health Accord is focused on how we can improve health outcomes, as well as on the social and economic factors that influence the health of our residents. As you may know, the Interim Report has been released and is available on Health Accord website. I would like to take this opportunity again to thank Sister Elizabeth Davis and Dr. Pat Parfrey, as well as the 6 committee chairs and all of the people working on the committees and working groups for the incredible work that they have been doing. I look forward to receiving the final report early in the new year. However, again, in the meantime, we know that there are challenges that need to be addressed in short order. So today I'm pleased to announce the steps our government, our department, is taking to improve access to primary health care in Newfoundland and Labrador. These steps are simply an early foundation upon which the recommendations from the Health Accord will be built. The first step is the opening of at least 4 new collaborative team clinics. We know that team-based care is best for patients. Students are being trained to work in interdisciplinary teams, and we know working in teams provides greater job satisfaction, as well as better health outcomes. We will ensure that health professionals who wish to work in teams will have opportunities to do so. Building on the success of the collaborative team clinic on Mundy Pond Road, Eastern Health will be opening 2 new clinics in the St. John's area. The current collaborative team clinic on Mundy Pond Road will be moving to Pippi Place. The new space, along with the addition of allied health providers, mental health counsellors and chronic disease nurses to the team, will allow that clinic to reopen its waitlist. It is anticipated that the clinic will be able to accept up to 1,200 new patients. This is in addition to the 2,600 patients who are already rostered to this clinic as their health home. 1 new clinic will be opened in the vacated Mundy Pond space, with a 2nd new clinic on Topsail Road. Both clinics are expected to be operational by mid-December. They will provide improved patient access by, again, providing a health home for those people who do not currently have one. These clinics will be staffed by primary care professionals, nurse practitioners, family physicians, nurses, and other healthcare professionals as required to meet the specific needs of their patient population. Additionally, I have asked the CEOs of both Central and Western to supplement the team-based care that's already being provided in their respective regions by establishing at least 1 new collaborative team clinic in their regions before the end of this fiscal year. The regional health authorities are working hard and diligently to achieve these timelines. More details about clinic registration for the Eastern Health clinics will be available in the coming weeks. Eastern Health will also be opening a walk-in clinic on Mundy Pond Road to improve access to non-emergency care and to alleviate some pressure on emergency rooms. Province-wide, we will work in concert with existing emergency services, and we're going to increase virtual care services to assist with the provision of urgent care in addition to existing services. As our population ages and our demographics change, we need to provide the right care for residents in the right place, at the right time, by the most appropriate provider. To assist in meeting this goal, we will be issuing a request for proposals for the development of a health human resource plan for the province. We will be working with the Workforce Readiness Group of Health Accord NL and creating a stakeholder committee to provide input on the request for proposals. The successful proponent will be required to engage with stakeholders. Earlier this year, we asked the Faculty of Medicine to host a workshop with key stakeholders to discuss recommendations for improving recruitment and retention strategies in rural Newfoundland and Labrador. And again, I'd like to thank Dean Steele and her team for the very helpful and comprehensive report from that workshop. Building on that workshop, to assist with the development of a more comprehensive provincial approach to recruitment and retention, we will establish a provincial health professional recruitment and retention office. The recruitment of physicians, nurses, pharmacists, psychologists, as well as the other valued healthcare professionals we need, will be strengthened by a provincial approach to support and modernize both new and existing HR practices and programs. We will be looking at seat capacity, growing our own, enticing people back to the province who've left, and welcoming health professional newcomers to the province. We will continue to work with the Department of Immigration, Population Growth and Skills to leverage their expedited immigration pathways, such as the Atlantic Immigration Program and the Priority Skills Newfoundland and Labrador Program. This will support the recruitment and retention of internationally educated healthcare workers and international medical graduates. Last year, we increased the seats in the licensed practical nursing program by approximately 90%. We increased seats in the personal care attendant program by approximately 70%. We commit to further increase the number of graduates from our LPN programs by 40% and PCA programs by 20%. Registered nurses play a fundamental role in the provision of quality care throughout the healthcare system. To help address the shortage of nurses in this province, we will increase the number of seats in the Bachelor of Science in Nursing program by 25%. We will do this by implementing a rural program with remote teaching. Recognizing the particular challenges associated with the recruitment of nurses, beginning at September of 2022, an offering of the Bachelor of Science in Nursing program will be available in Happy Valley Goose Bay, Gander, and Grand Falls, Windsor. I'm also pleased to announce that we will undertake 2 pilot projects to attract more new medical graduates to family medicine in our province. We will be establishing a program to guarantee income equivalent to that of a salaried family physician to new family doctors who open a family practice clinic or join an established clinic for the first 2 years of their practice. This will ease some of the uncertainties we've heard about the business aspects of opening a clinic, and it will do this by increasing their financial certainty. This guarantee will be linked to establishing a patient roster in the community and the provision of after-hours care. This program will also include a component where government will provide $100,000 to new family practice physicians who open a family practice clinic or join an existing family practice in the community and stay in the practice for 5 years. Both of these projects will be evaluated after a 3-year period to determine if they have had a positive impact on recruitment and retention. I'm also happy to announce that procurement will soon begin to support capital investment of $25 million in a phased redevelopment of the Health Science Centre emergency room. This redevelopment focuses on patient flow, but is actually integral to the new mental health and addictions facility. So as you can see, these are significant actions which we are taking to address the current challenges associated with access to care. These initiatives announced today, combined with our announcement last week on paramedicine and continued support for our existing programs, equates to an investment of over $30 million annually, in addition to the $25 million capital for the emergency room renovations at the Health Science Centre. These measures I've outlined today are important components to achieve improved primary care services for the people of the province, as well as competitive incentives for family physicians to establish a practice here. This is the foundation that will support the recommendations we expect to come from Health Accord NL. We value input from our stakeholders and will continue to work with them to improve our healthcare system. We need to collaborate to fix these challenges. We can't do it by ourselves. But these actions are just the beginning. On the federal level, we will be working with our counterparts to, I've lost my place here, there you go, yeah, to leverage monies onto their new programs. This will increase the number of primary healthcare teams in rural communities. This will do that by increasing by 50% over 5 years the maximum debt relief that family doctors, residents in family medicine, nurse practitioners, or nurses are eligible for under the Canada Student Loans Forgiveness Program. They will also expand the list of professionals eligible for forgiveness, and there will also be a one-time tax deduction of up to $15,000 over the first 3 years in practice. In addition, they have committed significant funds to generate 7,500 new posts across Canada for primary care practitioners, be they nurses, nurse practitioners, or family physicians, and certainly we will be working with them to leverage our share of that. As I've said it before, and I'll say it again, these challenges were not created overnight, and they won't be solved overnight either. I'd just like to take this time to extend sincere thanks to the staff of the Department of Health and Community Services. They have been under an amazing stress over the last 20 months. The work, the policy work that was started here in 2019 has been delayed significantly as we've seen waves 1 through 4 of COVID arrive, and they have to manage that and slow up on some of this work. So from my point of view, I want to commend the effort of all public sector employees over the course of the pandemic, because really it's been nothing short of extraordinary. They've kept our loved ones and communities safe whilst keeping access to important services. In closing, I want to reiterate that our focus remains the continuous improvement of a healthcare system in conjunction with our stakeholders that supports our health professional workforce. Our goal is better health and better health outcomes for the residents of Newfoundland and Labrador. Thank you very much. I will turn it over to Leslie to moderate.
Thank you, Minister. We have 4 reporters in person and 1 joining by phone. The first round of the question and answer session will give each reporter the opportunity to ask 1 question and 1 follow-up. Following this, there will be a final round where each reporter will have the opportunity to ask 1 final question. Our first questions are from Jody Cook with NTV. Please go ahead and make your way to the mic.
Hi, Minister. You'd indicated that a lot of this work, and you've mentioned it a couple of times now, began in 2019, policy efforts that have been ongoing and then sidelined, of course, because of COVID. In this documentation, there's some things that we knew already existed, some things that are new. What do you expect will be the most immediate implementation from this document that Newfoundlanders and Labradorians might reap the benefits of? Because this goes as far as renovations and brick and mortar. So some of this is going to be very far down the line, I would imagine.
Yes, I mean, there are short-term elements, medium-term and longer-term elements. The short-term elements in Metro will be within 6 weeks or so, you will see a significant increase in access to primary care across the province. Each of the RHAs has used virtual care and local initiatives to supplement gaps that have appeared over the summer. Traditionally, we see improvements towards the winter as the workforce stabilizes. But I think it's going to be, the issue is one of access, and that's what we're trying to fix in the immediate term. We have a major challenge with that, and that is where the pressure point is at the moment, and that's where the thrust of this is to go down that road.
So throughout the pandemic, intra-provincially, we've been moving healthcare workers around to support areas that need it the most. When you talk about opening up expanded walk-in clinics, that also means moving healthcare workers around. So some might argue that this is like a net zero gain or a robbing Peter to pay Paul scenario.
According to information from Eastern Health, which is the operational piece of the new clinics I've specifically referenced today, their biggest challenge is in actual fact finding clerical support and support workers to staff the clinic. My understanding from them is that they have no difficulty accessing primary care physicians prepared to work there. It's a different way of working. Patients will experience a different thing in Metro, something that rural has been used to for a long time. They will go to a health home and they will be seen by the most appropriate practitioner, depending on their needs of the day. So that might be a nurse, it might be a nurse practitioner, it could be a mental health and addictions counsellor, or it could be a family physician.
Our next questions are from Richard Duggan with VOCM. Please go ahead and make your way to the mic.
Thank you. For these new clinics that are being established, what's the estimated cost of doing this?
I thought you might ask that, and I do actually have it on a sheet of paper somewhere here. I don't seem to be able to find it immediately. Hang on, here we go. East End Torbay, probably 1.7 million. West End 1.6, nearly 1.7, and the walk-in at Mundy Pond 1.3. That would be the annualized costs.
And you mentioned issuing an RFP for the human resource plan. What sort of timelines is the department looking at to have that in place?
We would like to get that out as quickly as possible. I think one of the challenges there will be in actually finding the proponent time to consult with the stakeholders and yet not delay the outcome of the work. There'll be two elements to this. One is kind of what is it that motivates newly qualified residents to set up practice? What are their challenges? What are the things they're looking for? In addition to looking across the system, because the number of practitioners and the skill mix will depend on kind of the model that you have. And at the moment, we're using the collaborative team approach to determine that model. And so the numbers will shake out of that after they've done that work. The biggest, I think, will be the consultation phase before they can get the work done.
Our next questions are from Mark Quinn with CBC. Please go ahead and make your way to the mic.
Thank you, and good afternoon. You mentioned that we're setting up these new clinics, primary collaborative care clinics, and I think if I understood you correctly, you're suggesting that with the health accord, that will probably be the way forward long term. Does it mean that we're shifting away from relying on family doctors long term?
We are talking about access to primary care. If you look at the model that Dr. Parfrey and Sister Elizabeth describe in their interim report, it is they've suggested that we would need somewhere, I think, between 34 and 37 of these community teams. They envisage them as having various providers, and our mantra has always been the right care from the right person in the right place at the right time. So, you know, there's a significant amount of primary care that can be delivered by other practitioners, nurse practitioners, for example, nurses, and we would reserve then, if you like, the unique skill set of family physicians to deal with those more complicated patients where there were several competing clinical priorities. So it's a tiered approach. It's kind of like a physical version of step care.
And as a follow-up, one of the benefits of having a family doctor, of course, is continuity of care. They know you, and they know you over time and what your conditions might be and what your illnesses might be. Is that going to be a concern? Because my understanding is that the collaborative care clinics now, you may not see the same healthcare professional each time you're there. They have access to your medical records, I would imagine, but it's not the same person. And will that affect continuity and quality of care?
Well, I grew up in a household with many relatives in. This is a medical home. So if you're in need of care, you might not know whether it's your mum who's going to look after you or your granny, but you'll get the same level of care. That's it's the right person in the right place at the right time. There are skill sets that each group bring that are invaluable. And what I want to do, and what I've done over the last 5 or 6 years, is to ensure that practitioners work to the full level of their scope of practice. So we've enhanced the scope of practice of nurse practitioners. We've introduced different scopes of practice for optometrists. We have done this for midwives, and I would envisage each of those potentially having a role in a community clinic, working in their own area, and each playing a part.
Our next questions are from Daryl Roberts with CBC. Please go ahead and make your way to the mic.
Good afternoon, Minister. I'm wondering about this new recruitment strategy for family physicians. Do you plan on putting more supports in place for physicians to move to rural areas of the province? I'm just envisioning some who might just end up going to the, for lack of a better word, urban areas. If you know what I mean.
Certainly, rural recruitment has always been harder than recruitment in urban areas. There is under the current memorandum of agreement with the NLMA, a tiered top-up for compensation for areas that are designated as rural or remote or isolated to recognize that. Quite frankly, of late, it seems very much as though it's much more of a lifestyle issue. It's not so much about what you do when you're working, it's how your family and your children spend their leisure time and their discretionary time. And the successes we have seen in communities in recruitment have been where those communities have come out and put together a package and a pitch to attract physicians. So rural and remote is always harder than urban, and that I think will need to be addressed more formally as we go on. But there are rudiments there and foundations we can build on.
Thank you. And for this new human resources plan that is going to be put in place, I'm just thinking for family physicians or healthcare workers watching this now, thinking, well, how is this going to benefit me? How, I guess, do you envision this working?
Well, there's two elements to a health human resource plan. Well, there's many elements, but in terms of recruitment, there's also the retention piece. One of the things we've heard through our discussions with, say, the RNU or NAPE or the Medical Association is that working conditions do matter. So I think the information we have from, for example, Dean Steele's workshop around the business side of a practice for family medicine, not being appealing to new grads and current trainees. Those are things that the RHAs, for example, do very well. They organize clinics, they staff facilities. So that would be potentially areas where we could look at. Again, everybody's got a role to play, and the challenge with these situations is you've got to build a team, and a team of organizers and administrators as well, because there's no one group that can fix this by themselves. So I think if you address those in that kind of environment, then, if a specific issue arises in a local community, that could be addressed at the RHA or Family Health Network that we referenced earlier.
We will now go to the phone. Our next questions are from Peter Jackson with The Telegram. Please go ahead.
Good afternoon.
Hi.
Hi. The collaborative care clinics, there are a lot of doctors, as you, I think, suggested as well, who are semi-retired, on leave, operating much differently. With more of those doctors now in a situation where they can just give up a family practice and take a shift at a collaborative care clinic, how is that going to actually solve the family doctor shortage? It seems to me that it has the potential to add to it, doesn't it?
If you look at it purely from a physician point of view, I think you're taking a rather narrow view, because the thing about the collaborative team is workload doesn't just fall on one individual from a clinical point of view. So there are nurse practitioners, and there's evidence from the College of Registered Nurses that shows that 70% or maybe even more of a regular routine primary care can be managed by nurse practitioners, for example. There will be nurses available. There may be wound care specialists, diabetic educators, those kind of people who have a scope of practice, for example, for diabetic educators, that allows them to adjust insulin dosage independently within their own scope. So these are things a physician would not have to do. Therefore, between the team, the work is spread out more evenly, each to their own level of scope of practice.
Okay, and the other thing about these clinics, the one that was opened at Churchill Square was considered to be a way to be a stopgap against the lack of family doctors, and yet they stopped taking new names for care within a few months afterwards. Do you feel that these extra clinics will really put much of a dent in the ability of people to see a doctor?
I think so, because the structure of a community team should, in information I've been given, allow a significant number of people to be rostered to find a health home in each of these clinics. So if you've got 3 in total new collaborative care team clinics, each taking 5,000 or 7,000 people, that's 15,000 people who now have a home who didn't before. And that's on top of existing resources. So it does make a dent, because you're now going to have another one in Central, and you're going to have one in Western. The goal, I think, from Dr. Parfrey's interim report is that each community team would account for between 6,000 and 7,000 people. Obviously, geography might mitigate against that in very rural areas, because there might not simply be that level of population. But these are all steps in the right direction. This is not the end of our actions. This is not the fix in its entirety. This is just the next step in building on what we already have. And in the future, there'll be other announcements about different approaches in different areas, maybe more teams here, or some other enhancements to primary care. So, this is just a start.
Thank you.
I will now go back to each reporter to see if you have one final question. Jody Cook from NTV, do you have a final question?
Yeah, thank you. Minister, we heard from the finance minister on Thursday in relation to the NLMA's recent announcements that they're walking away from negotiations. We haven't had a chance to hear from you on this yet. So there's 2 key issues that they've brought to the table. Of course, one is that they say both yourself and the finance minister have unequivocally stated that there will be no more funding into physician services in this budget. And then secondly, union busting, ultimately. Can you respond to both of those issues for us?
Certainly. I think in the first one, the view from finance and from government is that $500 million for 12 or 1,300 physicians, depending on whose numbers you choose to accept, is not an unreasonable size of compensation. The issue about how it's distributed internally is as much the NLMA's decision as anybody else's. So that's one thing. The issue of the mandatory membership piece, this has been on the cards for 7 years. I actually told the CEO of the NLMA with the president of the day, face-to-face in fall of 2019, that the Pharmacy Act changes would have ramifications for all organizations that had mandatory membership. He actually acknowledged that last week when we met, that he had been told then. So it's a little intriguing, the timing of him coming out with that statement.
Richard Duggan from VOCM, do you have a final question?
I do, thank you. With everything that was announced today, there's quite a bit there. For people who, over the last number of years, have been having issues accessing medical services, how confident should they be that things in the short term with what was announced today will improve their situation?
I think they can be very confident. I have no information from the regional health authorities that would suggest that these are anything other than practical, implementable, realistic, and achievable in the short term.
Mark Quinn with CBC. Do you have a final question?
I do, thank you. I noticed that the 4 clinics that were announced today, the primary care collaborative clinics, are on the island of Newfoundland and Labrador. What do you say to Labrador? Why don't they get a clinic as well?
I think the challenge in Labrador is the same challenge that Labrador often has. We focused on recruitment of local talent, for want of a better word. I think a Bachelor of Nursing program in Happy Valley Goose Bay, along with some of the other training things that we have discussed with local staff there, will enable us to more readily build capacity in Labrador than a building or a virtual system. There is a need for a different approach simply because of the geography.
Daryl Roberts with CBC. Do you have a final question?
Yes, thank you. So for these new, recruitment, retention supports, specifically for opening new clinics in the province, for physicians who, like we've heard from some in the last couple of weeks who say they're done, they're going to move on to different jobs because they just can't afford to open the clinics right now. How long should they wait to open a new clinic now that they hear these new supports are being put in place?
Well, the funding for these is approved. The implementation period for the clinics in St. John's, for example, is around 6 weeks. The program for return in service and bursaries is mature. There are some elements in there that will need to be introduced, but the money will be there certainly from next fiscal year, if not this. Our bursary program has been incredibly successful. We have a very, very low attrition rate, dropout rate. I think it's less than 9% across all healthcare professionals, and the undergraduate medical one has 0 dropout. Everybody returns the service that we give them the bursary for. So I would regard them as very successful, and this will build on those. So again, always happy to hear from individual students or residents if they feel they've got a suggestion that would make Newfoundland and Labrador more attractive. Always open to new ideas.
Peter Jackson with The Telegram. Do you have a final question?
Yes, the NLMA has clarified that $500 million, of course, does not simply go towards compensation. It goes towards overhead, staffing, all sorts of other things that doctors have to cover on their own. But the question, I guess a lot of them would have is, why aren't we already putting nurse practitioners in these clinics that already exist and have doctors there already established?
Well, I mean, we're perfectly ready to entertain that suggestion. I think the challenges are around, who the employer would be. They are as much labor relations issues as anything else. From our point of view, the turnkey operation at Mundy Pond or at Topsail Road would seem to be the most attractive solution, judging by the fact that I'm told that there is no difficulty from Eastern Health's point of view in finding physicians prepared to do the sessional work. I think that would be probably my first response. I think we have made it quite plain with our actions around scopes of practice that other healthcare professionals are autonomous. They need to work in a team environment, but it's a team of equals. And so I think there are all sorts of considerations like that that really need to be addressed rather than simply, just dispatching someone to a clinic up the road. It's a team. We shouldn't have people working in isolation, but we need to get the team right, and that's what Eastern Health have been doing over the last little while.
Thank you.
Thank you, everyone. Minister, do you have any final comments for today?
Just really to sum up, I think this is a really substantive set of announcements. It lays out what we have done, lays out what we are going to do, and I think it is a major step in addressing some of our current challenges. It is not an end in itself, but simply the next step on the journey, and I look to being able to announce further ones over coming weeks and months. So thank you very much for your time, and as Janice would say, stay safe.
Thank you, Minister. Stay safe, everyone. Take care of yourselves and each other, and enjoy the rest of your day.